Hi friends, today the topic of discussion is basics of thyroid gland. We are just going to discuss about the basics today, and here a little bit of anatomy, a little bit of physiology, a little bit of embryology, all these things, and what are all the investigations that we do whenever we investigate a case for thyroid gland disorders. The manifestations of thyroid gland disorders such as hypothyroidism, hyperthyroidism, all will be discussed tomorrow. Today, a simple overview, bird's eye view of thyroid gland. You all know that thyroid gland is a butterfly shaped structure. So it is a butterfly shaped structure, and it has got right lobe and it has got left lobe, and in between you have a connecting tissue called as isthmus. It is a butterfly shaped structure below the level of the cricoid cartilage, in front of the tracheal cartilages, and contains right lobe, left lobe along with the isthmus. Sometimes a small extension we will be having just above the isthmus, that is called as pyramidal lobe. That is called as pyramidal lobe. And usually it is around 30 grams in an adult. So this is the simple anatomy with respect to the thyroid gland. Right. Next, what is the embryology of thyroid gland? What is the embryology? Now we are going to discuss about the embryology. Thyroid gland usually occurs as a diverticulum. Occurs as a diverticulum at the floor of the tongue from endoderm. This is very important. This question can be asked in your anatomy. So it arises as an endoderm diverticulum from the floor of the mouth. The site of origin is otherwise called as foramen cecum, otherwise known as foramen cecum, and from there it descends into okay, look at this, it descends. This is foramen of cecum, floor of mouth, and it descends, and it is the posterior most part of the tongue, and from there the diverticulum descends and in front of the hyoid bone, and then it gradually descends down and forms the thyroid gland in front of the tracheal cartilages. What are all the MCQs that can be asked here? One is it arises from endoderm as a diverticulum. The site of origin is foramen cecum. Right. And it forms a right lobe, left lobe, isthmus in front of the tracheal cartilage. Now, what are all the embryological issues with respect to this? Remember, if you find a, I repeat, if you find a midline cystic swelling in the neck, if you find a midline cystic swelling in the neck that moves with deglutition, what is that? That moves with deglutition or swallowing or protrusion of tongue. It is, unless otherwise proved, a remnant of thyroglossal duct cyst. It is the remnant of thyroglossal duct, and it is called as thyroglossal cyst. So somewhere in the midline, thyroglossal cyst, somewhere in the midline. Let me show you a video that was taken today. Look at this. This child was having Look at this. A swelling here, and it moves with the deglutition. Look at this. It moves with the deglutition, this area. So it moves with the deglutition, and this kind of midline cystic swelling that moves up with protrusion of tongue is called as thyroglossal duct cyst. Somewhere around here. Look at this. So this is the suspected thyroglossal duct cyst that forms from the remnant of the thyroglossal duct during its pathway of descent from foramen cecum to the tracheal cartilage. I repeat again, any midline cystic swelling that moves with protrusion of tongue, unless otherwise proved, it is thyroglossal cyst. And you all know, in surgery you will do some surgery. What is that surgery called as? Cyst trunk operation. What is that called as? Cyst trunk surgery, in which a part of hyoid bone will also be removed. A part of hyoid bone will also be removed. Right. So what are all the other features that can be asked along with this? One question is midline cystic swelling. Next question is, sometimes the diverticulum endodermal pouch that forms at the floor of the tongue, instead of descending into the tracheal cartilage, it can stop somewhere in the pathway. I repeat, it can stop somewhere in the pathway. So it has to come from the foramen cecum, in front of the hyoid bone, in front of the, what is that, laryngeal cartilages, cricoid, and then it has to come to trachea. Sometimes this diverticulum cannot reach the tracheal cartilage, and it can form something called as, very good, correct, what is that called as? Ectopic thyroid. So the second MCQ is, it can form an ectopic thyroid. So what is the difference between this ectopic thyroid? What is the manifestation of ectopic thyroid? Ectopic thyroid can also present as a cystic swelling in the midline neck. So what is the issue with respect to this? Any midline cystic swelling, most in favor of a thyroglossal cyst, but whenever you do an ultrasound, this thyroid gland should also be seen. When this thyroid gland is not seen, that midline cystic swelling should be an ectopic thyroid. You can remove thyroglossal cyst, but you are not supposed to remove your ectopic thyroid, because it is the ultimate source of the thyroid hormone synthesis. It is the ultimate source of thyroid hormone synthesis. So from embryology, there are two things that was taught to you. One is ectopic thyroid. Second one is thyroglossal cyst. Thyroglossal cyst means remove it by surgery. And what is the clue I told you? Moves with tongue protrusion. Moves with tongue protrusion. Whereas ectopic thyroid means normal thyroid tissue, normal thyroid in ultrasound neck, in front of trachea will be missing. So what you are supposed not to do not remove it. Do not remove ectopic, because it is the only source of thyroid gland. It is the only source of thyroid gland. So these are all the 2 points that you need to remember with respect to embryology of thyroid glands. Right. Next one. What is the physiology? Oh, before going to this, let me complete this one. What is this? A complex thing. not as complex as you think in terms of in thyroid follicles. In thyroid follicles, what will happen? Thyroglobulin will be synthesized. In thyroid follicles, thyroglobulin will be synthesized and then extruded out into the center colloid part. Extruded into the central colloid part. So one function of thyroid follicle. So where is the thyroid follicle? These are all the thyroid follicles. These are all the thyroid follicles. So these thyroid follicles produce thyroglobulin and it excrete into the colloid. And it excretes into the colloid. So this is function number 1. What is function number 2? Apart from that, this thyroid follicle takes iodine from the blood. I repeat, this thyroid follicle takes iodine from the blood with the help of sodium iodide cotransporter. Sodium iodide cotransporter. So that sodium comes in, iodine comes in. So sodium and iodine comes inside the thyroid follicle. And what will happen? This will be converted. This will be, so this iodine will be taken up by the thyroid follicle and this will also be extruded into the, so iodide with the help of thyroid peroxidase will be converted into iodine and extruded into the colloid. And this iodine as well as thyroglobulin, this iodine as well as thyroglobulin form something called as monoiodine tyrosine, diiodine tyrosine. This monoiodine and diiodine tyrosine combines together. So when one monoiodine and one diiodotyrosine forms, it will form T3. Whereas when two diiodotyrosine combines, they will form T4. They will form T4. So T3 and T4 will be formed and will be stored in the colloid. And when it is required, this T3 and T4 will be released into the circulation. Will be released into the circulation. So what happens? What are all the things that happens in thyroid gland are? One is thyroglobulin synthesis. Second one is iodine trapping transport. And the third one is coupling, iodine coupling with thyroglobulin. And finally, monoiodotyrosine, diiodotyrosine. And finally, you will have T3 and T4. T3 and T4 will be released predominantly it is T4. Major component is T4, whereas this T4 will be converted into T3 at periphery, and T3 is the active form at the tissues, level. So predominantly T4 will be secreted. This T4 will be converted by monoiodinase into T3 and T3 is the active form. Remember, you need to measure TSH and T4. You are not supposed to measure T3 because T3 levels will vary in blood, but T4 levels are fixed, right? And this thyroid will do all these functions once it gets stimulated by anterior pituitary. This anterior pituitary secretes thyroid stimulating hormone. This thyroid stimulating hormone acts on the thyroid gland to produce all these functions. And remember, this anterior pituitary is under the control of hypothalamus. This hypothalamus secretes thyroid releasing hormone. So step 1, hypothalamus secretes thyroid releasing hormone and it acts on the anterior pituitary, which in turn produces TSH. And this TSH acts on the thyroid gland to produce T4 and T3. Remember, this T4 and T3 has got negative feedback mechanism on TSH production and negative feedback mechanism on TRH. So what does it mean? Your TRH as a positive feedback mechanism or anterior pituitary. Your TSH has got positive feedback mechanism on thyroid, whereas the end product T3 and T4 has got negative influence on anterior pituitary and hypothalamus. Why is it so? When you have abundant T3 and T4, it means that the body doesn't need to produce further T3 and T4, so that it inhibits your anterior pituitary and hypothalamus. Right? Okay. So this is with respect to the regulation of the thyroid hormone synthesis. So anatomy, embryology, physiology we saw. Right. This is okay then. Now, what are all the things you need to do? Whenever it was already explained to you in detail that you always measure thyroid stimulating hormone, either T4 or free T4. Why free T4? Because your T4 will be associated with thyroxine binding globulin, This T4 will not be transported in the blood separately, Instead, it will have a companion called thyroxine binding globulin for stabilization. But there are so many factors which can reduce your thyroxine binding globulin, or it can increase your thyroxine binding globulin, as a result of which when you measure total T4, it is under the influence of this thyroxine binding globulin, so that it will not reflect true value. It will not reflect true T4 level. That's why we measure free T4. Free T4 means what? It is measurement of T4 without thyroxine binding globulin. Okay? Without thyroxine binding globulin. We don't measure T3. Why? Because it is highly subject to variation. Whenever body requires T3, your T4 will be converted into T3. So it is not that much stabilized value in our blood. That's why we measure thyroid stimulating hormone and free T4. And I had given you 4 case scenarios. Based on that, you need to tell me what is the diagnosis in case 1. Look at this. In case 1, free T4 is low. That means your thyroid gland is not producing thyroid hormones, but TSH is high. So what does it mean? There is a problem in thyroid gland. So thyroid hormones T4 is not produced. Since thyroid hormones are not produced, the negative feedback mechanism is not there. That's why your TSH value is high. So when T4 is low, TSH is high, it is called primary hypothyroidism. Otherwise, there is a problem in thyroid gland. You can understand now? Thyroid gland. Second one. In the second one, T4 is low and TSH is low. So what does it mean? Whenever T4 is low, TSH should be high. When TSH is not high, then it is called secondary hypothyroidism or central hypothyroidism. Or otherwise known as central hypothyroidism, where TSH is produced anterior pituitary under the influence of what? TRH. So when both T4 and TSH are low, it is central hypothyroidism. The problem is in hypothalamus or in anterior pituitary. Second point. So then the third one. So what is the third one? Okay, then the third one. Look at this. Your free T4 is normal, but TSH is high. How can it be possible? It means your anterior pituitary gland works more to compensate the reduced activity of the thyroid gland. So, what does it mean? Your anterior pituitary compensates for the low activity of the thyroid gland. That's why the third scenario is called as compensated hypothyroidism. That means T4 is normal but TSH is high. That is called compensated hypothyroidism. And finally, what is that finally? Free T4 is high, but TSH is very, 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 very low. What does it mean? This is called thyrotoxicosis. This is called thyrotoxicosis. So let me repeat once again. When your free T4 is low and TSH is high, this is thyroid problem. This is thyroid problem. It can be thyroid. Most common cause thyroid dysgenesis, that is absence of thyroid gland. The most common cause for congenital hypothyroidism. One. Second one, let me repeat again. In second one, free T4 is low as well as TSH is low. So what is this? This is secondary hypothyroidism. Hypothyroidism. So here this is called central hypothyroidism. The problem is in hypothalamus or pituitary. So here the investigation of choice is MRI, whereas in the first one the investigation of choice is ultrasound thyroid, because you can see whether thyroid gland is present or not. So let me repeat again. The third one is free T4 is normal but TSH is high. So what is this condition called as? Compensated hypothyroidism. Somehow or other he may go for low T4 in future. So this is compensated hypothyroidism. And finally, what did I say? And the final one is free T4 is very high but TSH is undetectable. Let me use this term, undetectable. It means thyrotoxicosis or hyperthyroidism. For example, Graves' disease. ठीक है? So the investigations of thyroid function is free T4 and TSH. Point number one. What are all the other thyroid functions we have? The another thyroid functions that we have is, let me finish, thyroid ultrasound. What is that? Thyroid ultrasound. First investigation of choice is T4 TSH. Second investigation for thyroid gland is thyroid ultrasound. So what happens in case of congenital hypothyroidism? If you keep your ultrasound probe over the trachea, absence of thyroid gland can be identified with the help of ultrasound thyroid. Second one, you can also find out an ectopic thyroid gland above the level of the tracheal cartilages. So your ultrasound will try to find out whether it is thyroid dysgenesis or agenesis or ectopic thyroid. This is with respect to congenital goiter. Apart from the location or identifying the thyroid gland by the ultrasound, the next most important use of ultrasound is a thyroid nodule. Okay, what is the role of this thyroid nodule? Look at this. I have shown you 4 pictures of thyroid nodule. So here this thyroid is, look at this. This is the thyroid gland. enlarged nodule, and the density of this one and this one are one and the same. And also this is the thyroid gland. The density is of this nodule and the surrounding thyroid gland is the same. So this is now isodense. But look at this. This is hypodense center. This is hypodense center. Hypodense center means Curie malignancy. That is cold nodule, otherwise known as cold nodule, Curie malignancy. But in the second one, look at this. There are echogenicity. In the last one, there are numerous echogenicity. They are nothing but calcifications. And look at this, the border is irregular. The border is irregular. So in a thyroid gland, when borders are irregular, when there are central calcifications and there is echogenic pattern, it is highly suggestive of not Curie, it is malignant nodule unless otherwise proved. And also this ultrasound will help you to take an FNAC by identifying the site of cold nodule. So what is the role of ultrasound thyroid gland? What is the role? One is identification, presence or absence of thyroid gland, presence of ectopic thyroid gland. Third one is identifying the features of the malignant cold nodule. Right. So thyroid functions, one is T4 TSH. The second one is ultrasound thyroid. Okay, then the third one is radionuclide studies. What do you mean by radionuclide studies? So nothing, these are nothing but you inject some dye into the body and these dyes will go and accumulate in the thyroid gland. So by looking into the pictures that can be taken after these dyes are getting accumulated in the thyroid gland, we can identify certain diseases. So how does this looks like? Look, this is how a thyroid scintigraphy will look like. Okay, this is how a thyroid scintigraphy will look like. And here there are two ectopic thyroid tissues. So what are all the thyroid scintigraphies you will use? So what is the difference between an ultrasound and radionuclide studies? Ultrasound will measure whether it is present or absent, hot or cold, whereas radionuclide studies are functional studies because majority of them utilizes iodine. This iodine is being trapped, iodination occurs and it forms an active integral part of the thyroxine synthesis. So this radionuclide studies will identify whether the iodine is getting accumulated, where it is getting accumulated in the just in front of the thyroid cartilage or above the level of the thyroid cartilage, and so many things. The two common radionuclide studies are, we use tracers are, one is technetium scan, technetium scintigraphy. What is that? Technetium scintigraphy. This technetium will accumulate in the thyroid follicle, so that through the scintigraphy study you can identify where the thyroid gland is present because by identifying the hot spots. The second one is iodine 123. This is an MCQ. Iodine 123 is also used for diagnostic purpose. Also used for diagnostic purpose. So to identify or to match, to find out the color of the thyroid, two things we use. One is iodine 123 and another is technetium scan. Then you must be asking why this iodine 131 is there. Remember, iodine 131 is not used for diagnostic purpose. It is used for therapeutic purpose. What do you mean by therapeutic purpose? This iodine 131 is cytotoxic, as a result of which they are used in malignant thyroid conditions. thyroid condition. You can ask me the same iodine 131 can be used for diagnostic purpose. You can use, but it has got cytotoxic effect. So iodine 131 is mainly used for therapeutic purpose. This question is often asked in initial, whereas iodine 123 is for diagnostic purpose. But majority of us we are using right now technetium scans. Right. So what are T4 TSH, ultrasound thyroid? Third one is radionuclide studies. So again a beautiful picture. Look at this. Central cystic swelling, unless otherwise proved, thyroglossal cyst. Right. Okay. Yes. Short revision. What are all the potential MCQs that can be asked? It is from endoderm. Second, what is that site? Foramen cecum. Third MCQ, what two midline swellings? One is ectopic thyroid. The second one is thyroglossal cyst. In thyroglossal cyst, normal thyroid will be present. So you can remove, thyroid gland is present. In ectopic, no normal thyroid. So don't remove it. Okay, 4. Right. Then, most common cause for congenital hypothyroidism is what? Thyroid dysgenesis. Thyroid dysgenesis. Right. Then, ultrasound will find out two things, whether it is present, absent, or it is in some ectopic area. Another beautiful point is it will find out cold malignant nodule. Malignant nodule. Seventh, four conditions pre T4 TSH. When pre T4 is low, TSH is high, primary hypothyroidism. Pre T4 is low, TSH either normal or low, secondary hypothyroidism. In first one, USG neck. In second one, MRI brain. 9. Pre T4 normal, TSH high, compensated hypothyroid. Compensated thyroidism. Compensated some. And finally, free T4 is very high and TSH undetectable. Hyperthyroidism. Hyperthyroidism. 10. 11. Iodine 123 and technetium 99 for diagnostic purpose. Whereas your iodine 131 is for therapeutic purpose. Okay, so with this we are finishing a bird's eye view on the basics of thyroid hormone. Meet you tomorrow by 9 p.m. Bye bye.